Welcome to the image analysis for the calcaneus. We're going to start with the AP axial projection. For the AP axial projection of the calcaneus, the talocalcaneal joint should be demonstrated as open. The calcaneal tuberosity is demonstrated without minimal distortion. Distal metatarsals are not demonstrated on the medial or lateral aspect of the foot. If they are, that should be an indicator for rotation. The sustentaculum tali is in profile. Proximal calcaneal tuberosity is at the center of the exposure field, and the calcaneal tuberosity talocalcaneal joint spaces are included within the exposure field. In order to demonstrate the talocalcaneal joint space as open, the central ray should be aligned parallel with it. In order to get that, the plantar foot surface should be positioned vertically at a 90-degree angle. The talocalcaneal joint space, when the foot placed vertically, is placed at a 40-degree angle with the plane of the IR. Thus, this is why we use a 40-degree proximal central ray angulation to align. It's used to be aligned with that talocalcaneal joint space. When the foot is excessively dorsiflexed and that central ray is not parallel with that talocalcaneal joint space, the projection will be demonstrated with a closed talocalcaneal joint space. The central ray will be aligned closer to perpendicular with that long axis of that tuberosity, and the tuberosity will be demonstrated less foreshortened. In insufficient dorsiflexion, the talocalcaneal joint space will be obscured, as in this demonstration, and because that central ray is aligned closer to parallel with the long axis of that tuberosity, the tuberosity will thus be demonstrated with excessive foreshortening. So the calcaneus is foreshortened in this image. When conducting image analysis of a calcaneus projection, rotation or tilting will be demonstrated by looking at the metatarsals. If the leg is internally rotated or the ankle is inverted, the first and second metatarsals will be fully demonstrated medially. If the leg is externally rotated or the ankle is everted, the fourth and fifth metatarsals are demonstrated laterally. As it is demonstrated in this image, we have some external rotation because you can see the fourth and fifth digit hanging out to the side here. So for our first practice analysis, the first thing you want to take a look at is, do we have all our anatomic structures? And we do have our anatomy that we need for the AP axial calcaneus. But next we need to determine rotation. And so we're going to look at those metatarsals and their positioning. And looking at the fourth and fifth metatarsals, they are hanging out to the side laterally. So this should tell you that there is some foot or ankle external rotation, and that we need to repeat this because your calcaneus or tuberosity will be foreshortened and not demonstrated in a true AP axial projection. Let's move on to the lateral projection. Image analysis guidelines for the lateral foot or excuse me, lateral calcaneus, state that the lower leg and foot are to be demonstrated at a 90-degree angle with a neutral ankle joint. The proximal talar domes are aligned. Tibiotalar joint space is open. Distal fibula is demonstrated about a ½ inch distal to the distal aspect of the tibia. So the fibula, you should see it on the distal aspect of the fibula. In an average medial arch, 1/2 of the cuboid may be visualized posteriorly to the navicular bone. Okay. The talar domes should be aligned anteriorly and posteriorly. That's how you get that nice joint, open tibiotalar joint space. The posterior half of the distal tibia superimposes the fibula. The mid-calcaneus should be at the center of the exposure field. The tibiotalar joint, talus, calcaneus, and calcaneus articulating tarsal bones should be demonstrated or included within the exposure field. So let's take a look at leg elevation and how it impacts our imaging. When the proximal lower leg is elevated and you're taking a calcaneus projection, you should definitely look for your joint space, that tibiotalar joint space, and see if it is open. And in this case, it's not. And so when that happens, we need to determine if there's some rotation or if there's some leg elevation issues. With the proximal lower leg elevated, the lateral talar dome will be demonstrated proximal to the medial. So here's your medial talar dome, and here is your lateral. And so this is indicative of that proximal lower leg elevation, which really means just that the knee is placed higher than the ankle. We need to lower that knee. Also, less than 1/2 of the cuboid will be demonstrated posterior to the navicular bone. So down here, we don't even see the cuboid at all. So there's some elevation issues here. The distal fibula as well will start to move proximally instead of being demonstrated aligned with the mid tibula, and the posterior half of that distal fibula should still superimpose that tibia, but it will start to move, like I said, proximally here. So you just want to take a look at your positioning of that fibula as opposed to where it should be demonstrated when imaging a calcaneus. So let's take a look at when the lower leg or the ankle is higher than the proximal leg, okay? Just the opposite happens. If the distal lower leg is elevated for a lateral calcaneus, the projection will demonstrate the lateral talar dome distal to the medial talar dome. So here is your lateral talar dome, and you can see that the medial is right up in the joint space, which is closed here. More than 1/2 of the cuboid is demonstrated posterior to the navicular bone. You can see here's your cuboid. Whoop, my little arrows aren't that great today. Your cuboid is demonstrated, whereas in the previous picture, the cuboid is not even seen at all when there's proximal lower leg elevation. But when the lower leg is elevated, your cuboid will be much more in profile. Also, that distal fibula starts to move distally, okay, to the distal medial tibia. Your calcaneal joint that you can see right here is demonstrated as open, and then that tibiotalar joint space again will be demonstrated as closed. So we, again, both these projections are reasons for repeats because the calcaneus is not demonstrated in profile. Now let's talk about rotation in a lateral projection. When the lower leg is in external rotation, where the foot or the forefoot is has more pressure at the forefoot, where the foot toes are down a little bit more, the lateral talar dome will be demonstrated posterior to the medial. Here's your lateral talar dome, and then the medial is already pointed out for you. Also, you'll see that the anterior fibula is demonstrated posterior to the mid tibia on the resulting projection. So you can see that this fibula starts to move posteriorly in external rotation, and that means when your toes are down and your heel is rotated up a little bit. An internal leg rotation, where the heel is down and your toes are pointing up a little bit, the lateral talar dome will be demonstrated anterior to the medial. So the here's your medial if you can't see that. Okay, and the anterior distal fibula is aligned more anteriorly to the mid tibia on the resulting projection, and you can see that that fibula moved anteriorly. So this is when when your heel is down and your toes are pointing up. So utilize your anatomic structures and your misalignments to determine rotation. So let's take a look at this practice analysis. The first thing you want to ask yourself is, do I see a joint space? And I do see something of a joint space. So we're going to also look at where are our talar domes? Does one look like it's on top of each other, or does it look like one is in front of the other? And in this case, one is in front of the other. The medial talar dome is positioned posterior to the lateral talar dome, which should indicate to you that the leg was internally rotated. You also want to look at that position of that fibula. It started to move anteriorly, which should let you know again that that leg was internally rotated. In order to correct this image projection, we need to take a repeat by externally rotating the leg until the lateral foot surface is positioned parallel with that IR. Thank you for participating within this image analysis. If you have any questions, I will see you out at clinic, or you can email me.